The numerator or the surface tension, if we keep it constant in both the alveoli with different radii, you will find that this alveoli has a decreased radius and the pressure here therefore would be more because it is inversely proportional to the radius. So the descending pressure would be high. So if you have an equation where the numerator is constant, which is governed by the surface tension, and the radius here is 1 for the smaller alveoli, because this is double the size of the smaller alveoli, the radius here is 2, you will find that the descending pressure in the smaller alveoli is 6 as compared to 3 in the larger alveoli, which means that if there was no mechanism to decrease surface tension, which was common at the numerator, the smaller alveoli will empty into larger alveoli and the whole architecture of the lungs will become unstable. So how is it stabilized? It is stabilized to maintain their normal volumes by means of surfactant. Now the surfactant here has an important role to play, making sure that the numerator is now decreased. So what you will find that with the presence of the surfactant, the numerator is decreased and therefore the resistance is increased and the pressure is now constant. How is that the numerator is increased? Because the amount of surfactant present in the smaller alveoli as compared to the surface area is much higher. So that is why the surface tension here has decreased to 1, whereas the amount of surfactant present in a larger alveoli, the molecules may be the same number, but for that larger alveoli, this surfactant is less in quantity, therefore the surface tension is 2. It is not decreased as 1 here. Hence, the descending pressures in both the alveoli are kept constant at 2 and therefore the lung architecture is maintained. And that baby lung concept doesn't exist, it occurs only in ARDS, and that occurs because of loss of surfactant in those areas, especially in the respiratory distress syndrome which we encounter in small kids. So this is because of the presence of more surfactant per unit area of the lung or volume of the lung, and this is less surfactant which is present. So the role of surfactant is to reduce the lung recoiling pressure, reduce the work of breathing, and therefore reduce the work to open the collapsed alveoli. It avoids alveolar collapse, stabilizes the alveolar size. Now let's come to the airway resistance. Is the timer kept there? I don't have an idea. Anyway, so the airway resistance is nothing but the opposition to the airflow in the respiratory passages. That is the impedance which is offered to the airflow. And how do you define resistance? It is the change in pressure or the pressure which is required to produce a unit change in gas flow. That is how resistance can be defined. So it can be an elastic resistance, it can be non-elastic resistance. Elastic resistance we have already talked about, which is determined by the compliance. The non-elastic resistance is the airway resistance. And it can be produced because of the laminar flow produces less resistance, whereas turbulent flow can increase the resistance to the airflow. So this is the equation for flow where it is mentioned about pressure gradient divided by the resistance. So if you have to talk about resistance, it is the pressure required to cause a unit change of gas flow rate. That is how resistance would be defined. There are increased airway resistance which can occur because it can be flow related, it can be volume related collapse. But let's talk more about the flow related collapse because that has got a more pathological value or important clinical value as far as we are concerned. So there can be airway collapse which can be flow related. Normally if you see, as I told you, the mouth pressures are 0 and the alveolar pressures are 0. That is when there is no flow occurring across the alveoli. This is at the end of inspiration. The end expiratory muscle is 0 because they are not acting at all. The inspiratory muscle force is inactive. and the pleural pressure is -10. That is at the end of inspiration. Now, when the expiratory muscles force the volume of the gas to be expired out or to be expelled out of the alveoli, there is an expiratory muscle force which is produced. If it is produced to +20, the same would be transmitted to the alveoli, and therefore the pleural pressure also becomes positive by 10. It was -10, so if you add 20 to that, it will become +10, and the intra-alveolar pressures would be +20. This force will help the alveoli to empty out, and as you see, the pressure from the alveoli to the mouth will gradually fall before it becomes 0, and the flow will cease to stop and no more alveolar emptying will happen. So there is a point where the pleural pressure will equal the passage in the airways, let us say at 10. And this occurs at somewhere in the 11th and the 13th bronchiole, and this will cause a collapse of the airway at that particular time, which is called the equal pressure point, when no more of the alveoli can empty because the pleural pressure is now equivalent to the pressures present in the small airways at that particular time. And this is what will lead to air trapping inside the alveoli. So the forced expiration which the people with COPD demonstrate, that is what is required to, they want to expel that air out, but in the process they end up producing extra amount of pressure, and that extra amount of pressure, expiratory pressure which they produce trying to expel the airway, actually causes flow related collapse of the smaller bronchioles, and it causes airway trapping. And once the auto PEEP or the airway trapping occurs, you will have to give some sort of external PEEP to keep that airway open so that the alveoli can keep emptying out. So this is what is the dynamic airway compression which we generally talk about, and this occurs once the patients breathe heavily, they have an increased rate, or they try to exercise or do something while having airway compression. So the dynamic airway compression, if you look at what happens, the resistance is increased. Therefore, there is higher positive airway pressures at the end of the expiration in the alveoli. So rather than being +2, it is somewhere as +10. And that causes airway trapping. And when the airway trapping occurs, the inspiratory muscle force has to generate that extra amount of pressure to overcome this pressure which is already increasing before normal respiration can ensure. So that needs an extra inspiratory effort by these patients. So if you look at this diagram, this is the normal tidal volume which the patient is breathing at. This is the normal FRC, and this is the total lung capacity. So with hyperdynamic inflation, you will find with each respiratory breath, the tidal volume will slowly come down or may be the same, but the functional residual capacity increases remarkably, though the total lung capacity cannot exceed to what it is. So what is the physiological problem here? There is increased intrathoracic pressure, decreased venous return, and that leads to increased inspiratory flow rate, decrease in tidal volume. And you need to have that external PEEP applied to match the alveolar pressures which are existing so that they can continue to be emptied out. So in conclusions, the mechanics of breathing need a central control, which normally they control the respiratory muscles, which in turn produce a pressure gradient for the movement of the air across the airways. So these pressure airway gradients, we need to remember the airway pressure gradient is basically there across the airways. The transpulmonary gradient is because of compliance. The lung compliance, the transthoracic is because of the chest wall compliance. So the alveolar compliance again is determined by the elastic forces, the surface tension, and the airway resistance. Thank you very much.
Thank you, Professor Kundra. I think we all have gone back to our college days when we used to learn this respiratory physiology. As we are running very late, actually we started quite late, so we can have just a couple of questions if we have at this point in time. Just 2 questions from the audience.
Yeah, please.
Can we have a mic in the audience?
Good morning, sir. Sir, while ventilating a patient of COPD, that time when there is like generation of auto PEEP, how much of external PEEP should be given?
See, the external PEEP is something which will keep the alveoli open. If this is the alveolar pressure of 5, suppose the auto PEEP is at 5, okay? If I keep it at 6, the external PEEP, this PEEP is going to hinder, because the pressure is high, again it is going to hinder the alveolar emptying. So it has to be somewhere less than the auto PEEP or maybe equal to the auto PEEP, so that from a higher pressure in the alveoli, it comes to a lower pressure, but keeping the lower airways patent so that they are not collapsing. So the intra-alveolar pressure, which is the auto PEEP, if you can determine that, most of the ventilators will tell you, keep the external PEEP almost at the same level. That should be good enough for alveolar emptying.
Thank you, sir.
But also remember that the kind of ventilation which you keep the patient on, the ventilatory mode, can also influence auto PEEP. So normally what we would say that you will require a more expiratory time to occur for the alveoli to empty. So apart from external PEEP, you will have to make sure that the IE ratios are adjusted to an extent that you allow more expiratory time, which means that if that has to happen and if the tidal volumes have to be kept constant, then the inspiratory flow should be very high. It will go almost to 100 liters per minute. So your inspiratory flow has to go up to make sure that the volume is not compromised, so that you can still allow some more expiratory time for the alveoli to empty and the expiration to complete. So the flow volume trace will tell you whether there is air trapping or not in the expiratory flow pattern area. Make sure it returns to the baseline gradually, not abruptly.
Thank you, Professor Kundra.
Thank you, sir. Thank you.
Now we'll move on to our next session in this Dr. Venkatesh Selvaraj, who is going to speak on perioperative blood transfusion. This is something which we all often come across, perioperative blood transfusion, and it is the duty of the anesthesiologist or the perioperative physician who is going to determine the nuances of blood transfusion. So, Dr. Venkatesh is going to tell about it.